Greetings. I'm Paul Zeeb, the Medical Director for MEC EMS, and this video today is to discuss protocol changes effective January 1st, 2017. These protocol changes are visible on this first slide. The outline of protocol changes will be available in the 2017 protocol and can be found under the references section. We have about a half a dozen things I'd like to discuss and review with you.
A summary of the changes made to our protocol will be found in the reference section of the protocol once it's issued for your use. Look under tab E and you'll find the changes that are specific to January 1st, 2017. In reviewing this, I'd like to point out that we've made some changes to sepsis, which revises the protocol to be more current with current practice. We've made a change to our management of toxic exposure, particularly patients who may have suffered from cyanide poisoning either as a result of smoke inhalation or poisoning to the chemical directly. In this, we've removed sodium thiosulfate, which really was not a great antidote for cyanide, and added the cyanokit, which is a much better antidote. For head trauma, we've added a reference box that indicates and lists those medications which are anticoagulants, which increase the patient's risk for CNS hemorrhage after head injury, even after relatively minor head injury. We've made some adjustments in our pediatric protocol. Sodium bicarbonate has been removed as a drug indicated for use in children under 5 kilos. Generally, these children have a respiratory, not primary cardiac arrest, and need for sodium bicarbonate is unlikely. This will allow us to remove the low dose or half strength sodium bicarbonate from our medication list. We've added a new protocol, which is pediatric behavioral emergencies. This was drafted by Dr. Wendy Stevens, our Associate Medical Director for Pediatrics. We've also made some revisions to the pediatric pain control protocol in that we can now use ketamine at a dose of 0.2 milligrams per kilogram to augment pain control in children whose pain is not adequately controlled by fentanyl alone. We've also added the cyanokit to pediatric toxic exposures. We've made a change to the cyanokit pharmacy reference so that we no longer have to consult medical control before administering the drug. We have made some revisions to the ketamine drug information sheet to reflect the changes made elsewhere within the protocol. Again, we've removed the indication for use of sodium bicarbonate in children under 5 kilograms. The pharmacy medication sheet for cyanokit has been added, and we have removed sodium thiosulfate. We have made some changes to the termination resuscitation clinical standard. I'll go into more detail when we get to that later. We've made a change to the last part of the RSI protocol in that we have standardized doses for fentanyl and midazolam for patients who have already been intubated and require sedation for transport. This is consistent between adults and children. Finally, not listed on this protocol change sheet is we made it an additional indication to TXA, in that TXA is now indicated for suspected hemorrhage, not just in verifiable hemorrhage. Moving on to specific changes, our sepsis protocol has been around for 4 or 5 years. Changes have been made to how we manage sepsis at the hospital, and this protocol has been revised to reflect that. In addition, there is a recent article published that indicates end-tidal CO2 does correlate with serum lactate, in that an end-tidal CO2 of less than 25 highly correlates with a serum lactate of 4 or higher. In the emergency department, we consider lactate over 4 to be significant and indicative of severe sepsis. So looking at what we've done to the protocol for sepsis, there still has to be a strong suspicion of infectious disease. To that, we have added physical criteria that can be assessed for the patient. So if the patient has abnormal temperature, heart rate, or respiratory rate, if 2 or more of those are abnormal, then they meet the second criterion for treatment of sepsis. And finally, end-tidal CO2 should be measured in any patients who may be suffering from an infection. And if that end-tidal CO2 is less than 25 millimeters of mercury, they should be considered for treatment for sepsis. So in summary, if the patient has an infection suspected, they have abnormal vital signs as indicated, and an end-tidal CO2 of less than 25, we want them to be treated for presumed sepsis in the field. For us, that treatment means intravenous normal saline as a fluid bolus. That fluid bolus is calculated at 30 milliliters per kilogram as a bolus as rapidly as possible. We recognize that for those agencies with short transport times, they may not be able to administer the full bolus, but we like them to start the bolus and communicate to the hospital that the bolus is being given. We also would like the transporting agency to contact the receiving facility and request a sepsis alert. Finally, if the patient has received their fluid bolus and they remain hypotensive, then we have an indication for epinephrine drip at a rate of 2 to 10 micrograms per minute, and that can be administered as per the protocol for epinephrine. This is a copy of the abstract of the article that I referenced. If you have an interest in seeing the whole article, let me know. But essentially what it says is that patients who are presumed to be sepsis and have an end-tidal CO2 of less than 25, that end-tidal CO2 is consistent with having a serum lactate over 4. Here's a extraction from our sepsis protocol, and I specifically identify those 3 parameters of temperature, abnormalities, heart rate, and respiratory rate to be considered, as well as the end-tidal CO2 of less than 25. If they have a suspected infection to go with that, then we should quickly check them for acute pulmonary edema, and if there's no evidence of that, initiate that fluid bolus at a rate of 30 milliliters, or a dose of 30 milliliters per kilogram, infused as rapidly as possible. And again, if the patient meets criteria, request a sepsis alert by the receiving facility. I made reference earlier to changes in our toxic exposure protocol. The top half, or 2/3, is unchanged from before, but we've added 2 arms near the bottom that have to do with smoke inhalation or carbon monoxide poisoning, with the second arm of being suspected cyanide poisoning. So suspected cyanide poisoning by itself is rare in our treatment areas. However, it may occur as either an intentional overdose on insecticides or other chemicals, an occupational exposure at work, or the patient may be a victim of poisoning by somebody else. I think it would be unlikely that most of us be able to recognize a cyanide poisoning in the field unless there was an empty bottle or some other direct indicator that the patient was administered or self-administered cyanide poison. The more likely scenario is that we're going to have a patient with smoke inhalation. We may suspect CO poisoning as part of that. And now we are going to use the cyanide kit for patients rather than sodium thiosulfate. We've also added another indication in this category, in that if a firefighter goes down at the fire scene and they've been actively involved in suppression in the interior, or are part of the overhaul process, and then they suffer a cardiac arrest or become physically, medically unstable, then we will treat them for suspected cyanide poisoning. The more common scenario, though, is we have a victim at the fire scene who is suffered a confined space exposure to smoke. They have an altered level of consciousness, and they have nasal sooting or nasal and oral burns. If the patient meets all 3 of these criteria, then they should be treated for cyanide poisoning. Our treatment is the cyanokit. It is a desiccated red powder. It has to be diluted with 200 milliliters of normal saline. The container, which is glass, has to be gently agitated but not shaken, so they recommend tilting for a minute or 2 to assure that it's fully mixed, and then the medication is infused over 15 minutes. Here's an extraction of that treatment process. So again, we have the two indications, firefighter down or victim of smoke inhalation. For the victim of smoke inhalation, they meet those three criteria we talked about of confined space, smoke exposure, altered LOC, and nasal or oral sooting or burns, or the patient that has a suspected cyanide poisoning. They're going to get the cyanokit intravenously. Pediatric toxic exposure is similar. The algorithm has it on the left lower corner, and it gets basically the indications for cyanokit in a child is suspected cyanide poisoning or, again, smoke inhalation, meeting the same three criteria that we apply to adults. In a child, the dosing for the cyanokit is 70 milligrams per kilogram, also infused over 15 minutes to a maximum dose of 5 grams, which is the maximum adult dose. Again, here I've pulled it out for you so that you can see that we're talking about those two indications for children. Again, cyanide poisoning or smoke inhalation with altered mental status, confined space exposure, and nasal or oral sooting or burns. Here's the drug information sheet for the cyanokit. The cyanokit is basically a vitamin B12 precursor. Cyanide joins with this chemical and forms B12. The greatest or the most common side effect of this medication is mild hypertension. For many of our patients who may be victims of smoke inhalation or cyanide poisoning, they are going to be hypotensive, so a little increase in their blood pressure is inconsequential and may actually be beneficial to the patient. Again, we have, for adults, it's a 5-gram vial or bottle of dry desiccated medication. We mix it with 200 milliliters of normal saline and infuse it over 15 minutes. For children, we mix it in the same fashion, but you have to calculate a dose of 70 milligrams per kilogram, infused again over 15 minutes. I'd also like to point out that authorization for administration of this medication by medical control is not needed. Cyanide is a metabolic poison that acts in seconds to minutes, and any delay in waiting for authorization to the or by a physician to administer this medication could result in bad outcome for the patient. There is a link listed, and you also received it via separate email to the cyanokit reference video library. I suggest you review that, particularly the first 2/3 of the video, which has to do with the review of cyanide poisoning, and also has a video or contains a demonstration of how to mix the medication and administer it. The last third of the video or so has mostly to do with the drug information sheet that's required by the FDA. I'll leave it up to you to decide whether or not you want to watch that last part of the video. But I strongly recommend that you watch this video as a point of learning for recognition of management of cyanide poisoning and how to carefully and safely administer the medication. I mentioned earlier that there is been a mild or a change to our head trauma protocol, and the only change has to do with the listing of medications which are anticoagulants and increase the patient's risk for intracranial hemorrhage. I would read this, make sure you're aware of those medications. Any patient with a head injury who's on these medications should be offered transport to the hospital because they most likely require a CT of the brain to evaluate for intracranial hemorrhage. Looking at pulseless or pediatric pulseless arrest, the only change to this is the bottom right-hand corner of the protocol, and that specifically has a note that sodium bicarbonate is not indicated in children less than 5 kilograms. We have done this because children of this weight who suffer cardiac arrest generally have a cardiac arrest as a result of a respiratory arrest, and the treatment of their acidosis is not bicarbonate, but providing adequate ventilation to the patient. We've also have a new protocol that relates to pediatric behavioral emergencies. This was drafted and developed by Dr. Wendy Stevens, our Associate Medical Director for Pediatrics. It has a format similar to what you would see in the adult protocol. However, the top right corner has a box that identifies guidance for destination decisions, and at the bottom of the page we break the children up into agitated and combative versus agitated. The child that is agitated but not violent should be medicated if necessary with midazolam or Versed alone. The child that is combative, agitated, and puts themselves or providers at risk for physical harm, they should be treated with ketamine. The intravenous ketamine dose is 0.5 to 1 milligram per kilogram, IV or IO. The intramuscular dose is less than what we have for adults. In adults, our intramuscular dose is 4 milligrams per kilogram. In children, it's 2 to 3 milligrams per kilogram. The other difference from the adult protocol is that if a child is under 12 years of age but requires ketamine, we do not need to co-administer midazolam or Versed, whereas if the child is 12 years of age or older, we should co-administer midazolam with the ketamine. On this slide, I've pulled out the box that identifies destination decisions. Children or adolescents that are pregnant but suffer a behavioral emergency should not be transported to Children's Hospital. Nationwide Children's does not have the ability to provide obstetrical care to these children, and they may need it as part of their assessment for their psychiatric illness. Children that are age 12 years and less with a behavioral emergency should be taken to Nationwide Children's Hospital. Any child who's under age 18 and needs medical stabilization should be taken to Nationwide Children, particularly if they have a chronic illness for which they're being followed at Children's. Children that are, or adolescents that are of age 13 to 16 have a behavioral emergency and are combative should be transported to the emergency department. And then adolescent patients who are in the age range of 16 to 18 and are medically stable should be transported to an adult facility. This is just an extraction of what we already discussed regarding treatment of the pediatric behavioral emergency, depending on whether the child is agitated alone or agitated and combative.
We have also updated the ketamine drug information sheet. We have added an indication in adults that ketamine can be used in patients with intractable abdominal pain inadequately controlled with fentanyl. We have also added to the drug information sheet indication for use in pediatric patients who are combative. Again, the dose is 1 milligram per kilogram IV or IO, or 2 to 3 milligrams per kilogram IM. We've also added the comment that Versed or midazolam must be used and co-administered in combative children ages 12 and over.
I discussed or mentioned earlier that we've made some changes to our clinical standard of termination of resuscitation. The first is that we have removed end-tidal CO2 of less than 12 as a metric that has to be met before you can terminate resuscitation. In other words, if your patient is not responding to your resuscitative efforts, but their ETCO2 is over 10, or regardless of what their ETCO2 is, you can terminate resuscitation without meeting that threshold of less than 10. We've added an exclusion criteria in that pregnant patients of 20 or more weeks gestation should be rapidly transported to a receiving facility. Your scene time should be minimized, and ALS interventions should be performed in the truck as it's moving down the road to the hospital. We do this because these patients may be candidates for perimortem cesarean sections. That is not a pre-hospital procedure for paramedics, but the longer the delay is in resuscitation to the time of cesarean, the less likely that you'll have a viable child delivered. So again, if you have a pregnant patient who is in cardiac arrest and they are of 20 or more weeks gestation, they should be rapidly transported to the emergency department for possible perimortem cesarean. While we have removed capnography as a requirement for termination resuscitation, we have added a comment to our operating procedure that capnography should be used to monitor the patient's CO2 level during their resuscitative efforts. This is so we can verify tube placement, and it may also be used as an indicator regarding the adequacy of CPR and other resuscitative attempts. and you may consider the patient's end-tidal CO2 in your termination decision, but it's not an absolute that it has to be less than 10 in order for you to stop the resuscitation.
With our revision to our clinical standard on termination resuscitation, we've also added an optional checklist. This checklist is shown here and is broken down into two components. The first component is a list of 8 questions that all must be answered no. The second component is a list of 5 questions, all of which should be answered yes. If all the appropriate checks are met, with our revisions to our clinical standard on termination of resuscitation, we have added a checklist. This checklist is optional and may be used at the provider's discretion to determine whether or not a patient is suitable for termination of resuscitation. The checklist is broken down into 2 components. The first is a list of 8 questions, all of which should be no, and the second component is a list of 5 questions, all of which should be answered yes. If all of the criteria are met, then termination may be terminated.
We have made one change to our RSA policy. It's limited to the bottom of the page, and I'll jump to that extracted slide. What we have done is we have standardized the fentanyl dose for sedation after successful intubation, and that is 2 micrograms per kilogram IV or IO. That's regardless of the patient's age. Versed is used at a dose of 2 milligrams IV push, or for children 0.1 milligrams per kilogram IV or IO to a maximum dose of 2 milligrams. And then these 2 medications are co-administered. They may also be repeated every 20 minutes for 2 more doses if necessary during the patient transport to the hospital. Finally, I mentioned a change to our TXA medication information sheet, and TXA is now indicated not just in verifiable hemorrhage or hemorrhagic shock of moderate to severe severity, but also if the patient has suspected hemorrhage or hemorrhagic shock. So if you have a patient with penetrating injury to the abdomen and they are not hypotensive, but you suspect based upon the location of the wound that they are going to be a victim of significant hemorrhage, then you may administer TXA in the field even though they do not show clinical evidence of shock.
This has been a quick review of our 2017 protocol revisions. If you have any questions or concerns, please discuss them with your EMS coordinator, who can pass them on to me. Thank you.